So, say again, this can happen to any one of us, all right? It happens to good people. I happen to know that 2021, there was an esophageal intubation on the Isle of Man, and 4 anaesthetists spent virtually all of 2021 under investigation for manslaughter. Coroners know about this now. Coroners know it should not happen. There is a second victim. More than a second victim, okay? It can happen to any one of us. So, as Tim has already mentioned, and we'll discuss at greater length, clinical signs can't be relied on. It's all about capnography. So this is what we're going to talk about. There's reducing the occurrence and promoting recognition. I'm just going to talk about promoting the recognition of an esophageal intubation. It's all about capnography. So the Royal College of Anaesthetists a few years ago inaugurated this aphorism of no trace, wrong place. On the understanding that if you put a tube in the esophagus, you don't get CO2. Therefore, if there's no trace is the wrong place, people wrongly assume that if there was a trace, doesn't matter how abnormal it was, it must be in the right place. I'll come on to that in a second. But the other aphorism that we've used for over 50 years is, if in doubt, take it out. But as Tim has already alluded to again, people don't have any doubt. They've seen it go through the cords. They convince themselves that they have intubated this person. Therefore, there is no doubt. It must be another problem. It is usually a problem with the patient, according to them, in their own head. These are not bad people. They are trying to make an honest diagnosis, but they don't consider a mistake because they saw the thing go through the cords. So no trace, wrong place doesn't work because it is often an inadequate trace. So the problem, so that problem we've tried to address by coining a term, sustained exhaled CO2. So when you look at a capnograph trace of an esophageal intubation, there may be some CO2, but we've come up with 4 easily remembered and easily identified criteria that must be met to meet sustained exhaled CO2. And if you don't get sustained exhaled CO2, the algorithm will tell you what to do about that. So the algorithm is really a dodgy trace, how to manage a dodgy trace. So what are the criteria of sustained exhaled CO2? Remember, you were intubating this, okay? You'd go, I'm going to put a tube in there, and then I'm going to attach the capnograph, and then I get this trace. Oh, well, that's 3 millimeters of mercury, okay? But there is a trace, and it goes up with expiration, it goes down with inspiration when you squeeze the bag. But if in doubt, there is no doubt. You saw that thing go in, and the CO2. There must be something with there must be a problem with the patient. That is where sustained exhaled CO2 comes in. So the first one is that the level rises with exhalation and falls with inspiration. Okay? So you have to have, squeezing the bag, it moves. Consistent or increasing amplitude over 7 or more breaths. So it has to carry on, right? It can be low, but as long as it's coming up to at least a peak amplitude of 1 kilopascal, or 7.5 millimeters of mercury, okay, above baseline. And the reading has to be clinically appropriate. Let's go through some examples. So these are the 4 criteria. So this is the trace we got before with that intubation. So it rises and falls, but it doesn't meet the criteria because it's low. It's less than 1 kilopascal. Okay. What about this? There's no rise or fall with the inspiration, expiration. So that one fails. What about this? 2 millimeters of mercury. It's going up. There's no scale on this. I do apologize, but it goes up to 17 millimeters of mercury. Well, it is consistent or rising and goes above 1 kilopascal 7.5. So that one meets the criteria for tracheal intubation. Okay. What about this one? Well, that looks pretty good, doesn't it? That's fine in a sick person, okay? Because that is a very low end-tidal CO2. The cardiac pulmonary blood flow, cardiac output is bad. So if the clinical situation suggests that the cardiac output is very poor, well, actually, that meets the criteria. But that same trace, if you're doing elective anesthesia and you get this is not normal, right? So we've built in hard and fast rules that have to be met, and the assistant should confirm with the operator that sustained exhaled CO2 has been achieved. What about that one? Well, this is similar to some of one of Matt's cases. Starts well, but then reduces, still above the level, but for some reason something's going on. You just put a tube in, and something bad is happening to this patient. You just put a tube in and something bad is happening to this patient, the onus is on you to make sure that that tube is in the right place and isn't the cause, and is relatively easily done. So that's sustained exhaled CO2. 4 criteria, has to meet all 4 of the criteria. Operator and the rest of the team confirm that. That is the role of the airway assistant as well. So this is the algorithm. So failure to satisfy the criteria for sustained exhaled CO2. And it effectively asks 4 questions. Is removing this tube dangerous? Is the saturation adequate? Has esophageal intubation been excluded? And has sustained exhaled CO2 been restored? If the answer to any of those questions is no, you go to the blue box and remove the tube. Now, this takes a change in culture, because what we normally do is we want to be right. We don't want to take out a tube if it's in the right place, because that would be silly, wouldn't it? Well, actually, it isn't silly. We want to change from being people wanting to be right to people wanting to be safe. Okay? So this algorithm, built into it, there is a potential for taking out tracheal tubes, right? In other words, tubes in the trachea, correctly placed tubes. But that's because the cost of taking out a tube and then ventilating with a face mask or a supraglottic airway, it's not just taking out the tube, it's then ventilating 100% oxygen with a face mask or a supraglottic, okay? The cost of that is much lower than leaving a tube in when you're not absolutely certain. People get worried about taking out tubes. Well, there are 2 kinds of intubation, aren't there? There's easy intubation and difficult intubation. Well, if you just put a tube in and it was easy intubation, what's the problem with taking it out? Because it's easy. You're going to put it back in. It's easy. Okay? If it's a difficult intubation, you're worried about taking it out. Well, if it was a difficult intubation and you just got a dodgy trace, maybe you've put it in the wrong place. So again, the default response is to take out the tube. It's a smarter version of, if in doubt, take it out. But the sustained exhaled CO2 criteria raise the doubt and make that doubt hard and fast. Okay? So, I've talked about that really. It's the easy intubation versus the external intubation. Not about right. I've actually just delivered all my slides just to you without actually going through my slides. So, in the absence of an obvious and immediately remediable cause, it is simply to remove the tube and face mask ventilate. I actually was expert witness on one of those cases, and the tragedy was that the patient had been intubated by a registrar, and went off at the end of the case, re-intubated by a consultant, and then that was left in for 5-10 minutes. It was in the esophagus. Another consultant came in, said it was in the esophagus, took it out, put it back in the esophagus, right? This is not easy stuff, okay? Same problem. But the moment they took it out and ventilated with the supraglottic airway device, even when she was in cardiac arrest, they got a good trace, okay? All they had to do was take the tube out. So if in doubt, take it out, holds, but sustained exhale CO2 gives you a hard and fast reason. You're not going to be criticized for taking it out. So the 4 questions. Is removing the tube dangerous? Covered that. Well, when might it be dangerous? Really, that's the only time when that may be dangerous is if there is a massive aspiration risk, or there is significant reason to consider the patient will be difficult to face mask or supraglottic airway ventilate. Okay? So if you take the tube out and you can't ventilate them, and you're really worried that you're not going to be ventilating them some other way, you may want to leave. That may mean you say taking this tube out is dangerous. There's a very small minority of cases, but they do exist. So you are allowed to leave the tube in. So it's when face mask and supraglottic airway are difficult, massive aspiration risk. Okay. If it isn't dangerous, you take it out and attempt ventilation. And you essentially are getting back into face mask ventilation. If you can't get sustained exhale CO2 and you can't, and the saturation is going off, then obviously that's just failed airway management. You go to airway rescue techniques the same way. Right, so if you've said it is dangerous, you've got to declare the reason to the team, because that actually formulates it in your head. What are your thought processes? If you actually have to articulate something, it's going to make you think about it and make you justify it. So you declare the reason, call for help, and confirm 100% oxygen going down that tube. Then you've got to do 2 things. You've got to evaluate the other causes and actively exclude esophageal intubation. So how do you actively exclude esophageal intubation? First of all, repeat laryngoscopy, ideally with a video laryngoscope, plus one other, and then get another piece of equipment to, this is going to take some time usually, but get some other equipment to confirm either a bronchoscope, ultrasound, takes a long time, or an esophageal Doppler device. They've dropped out. They've become historically interesting rather than anything else, but they do work. So a 2-mechanism check with valid alternative techniques. Repeat laryngoscopy, as I say, usually video, by the most expert person in the room. Okay, this is the tube that Tim showed you. When you do repeat laryngoscopy, you've got to make sure you see it go between the cords, anterior to the arytenoids, because like that, as Tim alluded to, almost all these cases are diagnosed by a second operator. The fixation bias, people become so invested in their tube, they become so convinced that there's a problem with the patient that they very, very rarely identify their own esophageal intubations in the patients that die. It's spooky when you read the reports. So that's how you do repeat laryngoscopy, and then use a second technique. We're using bronchoscope, make sure you see tracheal rings and trachealis posteriorly. If you're using ultrasound, you're looking for the double tract sign. So you will see, basically, if you've got an esophageal intubation, you see it paratracheal. So you get this double tract sign. The esophagus should be collapsed and not seen. Esophageal Doppler detection devices, you can get those in the States, but we can't confirm that someone's still making them. We think there's just a massive old stock of them, but they do work. So if anything, if there's a problem with any of that, take it out. Attempt face mask ventilation. Has it sustained exhaled CO2? You must restore sustained exhaled CO2. If not, take it out. Okay. I'll come on to how you check for other causes in a second. So if we could run Tim Cook's clinical signs.
Hello, it's Tim Cook again. Now I'm going to talk about two relatively controversial aspects of the guidelines for prevention of unrecognised esophageal intubation, namely the role of clinical examination and of videolaryngoscopy. My conflicts have not changed since my talk 15 minutes ago. First, about clinical evaluation. So it's common to hear a trainee, even a consultant, any airway manager saying, I've got chest rise and misting, I'm happy, I'm going to listen to the chest and check the capnogram. What we don't say in the guidelines is that clinical examination is a pointless ritual. We don't say that clinical examination has no value. What we do say is that clinical examination has no value in excluding esophageal intubation. And that when you have a dodgy capnograph, so that is one without sustained exhaled carbon dioxide, clinical examination should not therefore alter the decision to take out the tube or not. We need to understand the limitations of clinical examination. So I'll briefly summarize the data. I'm not going to summarize it in great detail because this is Adam Law's data. It's not been published in full yet, and so I don't want to overstate it. Or give too much detail. So sensitivity, does a positive test detect the tracheal tube is correctly placed? Specificity, does a negative test correctly identify misplacement? Positive predictive value, if it's a positive, if the test is positive, what's the proportion that are in the trachea, and negative, the proportion that are not in the trachea. So in brief, misting. Misting is unreliable because many esophageally traced tubes will lead to misting. So the positive predictive value is low. It's unreliable for confirming the tube is actually in the trachea. It is good for, if there is no misting, for determining that as a sign it's in the esophagus. But because many of those are the cases where it is in the esophagus will also have misting, it's unreliable. It has poor sensitivity. So no misting is likely to mean that it's not in the trachea. It's a reliable test, but the presence of mist does not indicate that it's in the trachea. So it is unreliable for excluding esophageal intubation. Chest rise, there aren't really any robust studies, but it's very well recognized both from case series and from clinical observation that chest rise can and does occur when the tracheal tube is placed in the stomach and the stomach is ventilated, or placed in the esophagus and the stomach is ventilated. Auscultation, again, difficult to synthesize the data. The data is not as good as for misting, but there are multiple cases where esophageal intubation is preceded by auscultation of breath sounds, most notably first in the ASA closed claims guidance, where there were tens of cases where this was the case. There's also all the cases that we've looked at where auscultation was reported before esophageal intubation being detected. The individuals believed they had heard breath sounds. There is basic data showing that we don't have an ability to discriminate the sounds, whether the tube is in the esophagus or the airway. And it's likely that this test has even poorer sensitivity and specificity than other methods. In contrast, the esophageal detector device, you might want me to ask about this in questions, is good in terms of its positive and negative predictive value, its sensitivity and specificity. So it's a reliable, not perfect, but reliable tool for detecting that the tracheal tube is in the right place or that it is not. Videolaryngoscopy. Again, a matter of some controversy. I'd like to particularly thank the Cochrane group from Lancaster, led by Andy Smith, and particularly Andy Rogers and Jan Hansel, who've specifically looked at this. We recently published a science letter in Anesthesia, which is an add-on to the extensive Cochrane review, which was led by Jan and Andy. Regarding videolaryngoscopy and esophageal intubation, we found 40 studies, 3/4 of them done in theatre, 11 outside theatre, which looked at esophageal intubation. These of course are RCTs, mostly in controlled settings. And this may be enough for you. In those studies, direct laryngoscopy was associated with esophageal intubation in 3% of cases, video laryngoscopy with 1%. Now we'll come to some clever statistics. So if you look at all the studies combined, we find that, and again, so if we exclude non-theatre studies, so if we just look at in theatre, the rate of esophageal intubation is about 1 in 180 with video laryngoscopy, and fourfold that with direct laryngoscopy. If we look at all the studies from all locations, which have got massive heterogeneity both clinically and statistically, we find that video laryngoscopy reduces the rate of esophageal intubation approximately twofold. If we look at just hyperangulated video laryngoscopes, it reduces it between 2 and 3-fold, statistically significant. Macintosh video laryngoscopy has similar effect, a 2-fold reduction, but it's not actually quite statistically significant, and therefore should we throw this result away, or is that pandering to the p-value of 0.05 too much? And similarly with the channeled video laryngoscopes, which again reduce it 2-fold. For those who are interested in statistics, perhaps the minority, we used a random effects model, and we use this because it is probably the best model to deal with heterogeneity, both clinically and statistically. But it tends to soften the results. It perhaps misses results that are there. And we used it because of the heterogeneity throughout the various different outcomes in the Cochrane review. For esophageal intubation, however, the outcomes are relatively robust, and actually the heterogeneity in the studies is not as high as you might as is with other outcomes. And therefore, it may be appropriate to use a fixed effects model, which assumes low heterogeneity, or even a Peto odds ratio, which is particularly useful for events which are of low incidence, which, as we've seen, includes esophageal intubation. These are rare events. And if we do use those models, then with all the models, the hyperangulated video laryngoscopy is associated with a significant and dramatic reduction in esophageal intubation. And with the Peto and fixed effects, Macintosh also becomes significant. The effect size does not differ, but the lozenge narrows and therefore becomes significant. And the same applies to the channel video laryngoscopy. I leave it to you to make up your mind as to the importance of that. But let's remember that video laryngoscopy has other generic safety benefits: fewer difficult intubations, fewer attempts, fewer failures, less hypoxia. These are likely to be not just procedural, but also safety benefits. Fewer esophageal intubations, I believe, less airway trauma, and other benefits. And then the non-technical advantages are very significant. And as I said in my previous presentation, unrecognized esophageal intubation is all about human factors. So better supervision, allowing trainees to learn better, to complete intubations, to do what they couldn't do with direct laryngoscopy. It allows the assistant to identify problems early, to optimize or adjust cricoid force or anterior neck pressure. It improves dramatically communication and human factors, and also facilitates 2-person checks of successful intubation. So there are multiple advantages. And I think probably these human factors benefits exceed that technical benefit of reducing esophageal intubation. So I suspect it will reduce undetected esophageal intubation to a greater extent than reducing esophageal intubation itself. So in summary, clinical examination has limitations. It is unreliable at excluding esophageal intubation, and we should remember this. It should not influence the decision to remove the tube when capnography is dodgy. And video laryngoscopy reduces esophageal intubation in randomized controlled trials. We can argue about the statistics. And it also has many other relevant benefits. Thank you very much.
So I'm regularly in theatre with juniors, with people who've just completed their basic competency assessment to go on the rota and all the rest of it, and they put a tube in. The first thing they say is, "Oh, the chest's rising and the tube is misting," and that's it. They've job done. Off they go. But it really does. If the tube is misting and the chest is rising, but there's no CO2, what are you going to do? You're going to take the tube out. If there's CO2, but the chest is not rising and the tube is not misting, as long as there's a CO2 trace, like a sustained exhaled CO2 trace, you're doing the right thing. I was going to talk briefly about the role of the airway assistant, which is, I think, particularly germane to SAS. Query the view. Basically, if you routinely use a video laryngoscope, that helps the assistant actually agree with the operator, and the operator can demonstrate the anatomy and say, yeah, this is the view we've got. Verbally confirm the objective criteria for sustained exhaled CO2 and that the saturation is working. That Nick Crimes would say you're in the green zone. You can challenge the danger of removing the tube. You know, you've got to ask them, is it really dangerous to remove this tube? Why is it dangerous? If you're saying it's dangerous, why is it dangerous? And if someone has to justify or at least just explain, verbalize their thinking, that's when they often realize that perhaps their thinking isn't as robust as they would like to pretend it was. And that makes it easier to remove the tube, right? Removing a tube is not a failure. Even if it was in the trachea, you take the tube out, that's fine. It's not about being right, it's about being safe, doing the safe thing to avoid harm to the patient. As I say, prompt to remove the tube according to the algorithm and to observe outcome of valid alternative techniques. In other words, when you're doing a bronchoscopy or an ultrasound or whatever, to agree or disagree, support or otherwise, whether or not that is a valid outcome. And challenge the use of clinical examination, which I think will be quite common in the future. So basically, I left off last time. So this is the dodgy trace algorithm, remember. Failure to satisfy criteria for sustained exhaled CO2. Got to ask yourself, is removing the tube dangerous? If it isn't, remove it. If it is, if it's a saturation, okay. Because if it isn't, you've got a dodgy trace and the saturation is bad, you're harming the patient, take it out anyway. If the saturation is okay, that gives you time to actually actively exclude esophageal intubation. And whilst you're doing that, you'll notice that at the same level as yes, the first yes, below is removing the tube dangerous. On the left-hand side, we've got this thing called a quick check, and that's just a prompt to look for other causes of a poor CO2 trace. Okay, and there are lots of causes, and you've got to commit this to memory. So what we've done is basically come up with this thing of a quick check. It's just a prompt. There are essentially three ways. You just got to remember: exclude equipment causes, that is circuit causes usually, airway causes, problems with the tube, or patient causes. Okay? So essentially confirm the function of the CO2 detection device. Okay? Check your capnograph. It's usually come apart, it's usually blocked or kinked or whatever. Okay, if it is, happy days, correct it, get the entitled CO2 back, carry on. If there's a problem, if you suspect the problem with the tube, the first thing, one of the most important things to do is just simplify the circuit. Get rid of everything extraneous. If you've got a water circuit, for instance, that's probably the simplest way of doing it. Just remove everything apart from a brand new water circuit. Okay. Then check the airway, the tube itself. Is there a leak around the tube which may be reducing the entitled CO2 trace? Is the tube patent, pass a suction catheter or a bronchoscope? If there's then move your attention to the patient. A lot of these cases are ascribed to bronchospasm, ventilating a brick, oh, you can't move anything. But actually, when you read the coroner's report, the clinicians are saying, well, I listened to the chest, and I could hear breath sounds, and it was wheezy, but there was no CO2 trace. That does not make sense, right? If you can hear breath sounds, and you can hear wheeze, that means there is air movement, and there should be a CO2 trace, okay? But that cognitive dissonance again kicks in in the moment under stress. But you read that quite a lot, not universally, but they often ascribe it to bronchospasm. but then describe clinical signs, but then say they're moving air, but there's no CO2. And of course, you're going to do a pulse check. There is actually a final one, which is really weird stuff like tracheoesophageal fistula or bronchopleural fistula or an anterior mediastinal mass, but that's really context specific. So it's really about checking the tube, checking the circuit, check the patient. That's all you do. I'm not going to go into the rest of it because we've already gone over time. But I think we can now, those are the main parts of the algorithm, those are the main points we wanted to cover from the guideline, and I think now we'll do a Q&A session.
I've got a question. I find that the best way to get algorithms across to people and cognitive aids is to produce a suite of educational resources to go along with them. Is there anything that's in development for that?
Yes. I think that looking over here at Adam is it's work in progress with Adam. It has begun, and I think well, maybe you could talk to that, Adam, actually, because Adam Rehack is actually doing an educational package for this guideline.
Yes, so we're in the advanced planning stages with Nick about what that educational package will look like. And I'm sure it'll come to me at the top of Kilimanjaro next week on my 3 weeks break, exactly what it will look like. So it's not advanced quite to the degree that we would have liked, but it is going to be a hybrid approach so that we're going to produce a suite of tools that are deliverable in all locations. You won't need to require any sort of fancy simulation centre or mannequins to deliver it. I say hybrid because we're going to produce videos that demonstrate how it can be applied in various scenarios. And I think through the use of a few specific scenarios, you can really identify or help illustrate the different pathways that you can go down this, which you've clearly demonstrated. The patient where it isn't dangerous and you just take it straight out. The patient where it is dangerous to take it out, but the SATs falling mean that it doesn't matter, you're going to take those chances because, as you say, we're not winning, we're doing what we're doing. So we have to pursue oxygenation, ventilation through a different pathway. And then finally, the patient where we have got the saturations and a significant danger to pulling the tube, where we do have to effectively work as a team, not just continue doing what we're doing, stuck in the same confirmation bias circuit, but really get some fresh eyes in there and getting hopefully different people working down two different pathways, which one to actively exclude esophageal intubation, and then that other pathway of make sure there isn't something else going on. And really trying to cognitively deload the leader or the airway operator there to do that. So that will be a suite of videos and instructions that can be delivered in sort of any ICU unit, ambulance bay, anaesthetic department, and doesn't require too much fancy equipment. But unfortunately, we're not as far advanced as we would like in the production of this.
Yeah. I mean, this. I think it's useful to point out that one of the things this grew out of was this is a problem around the world and it's becoming particularly topical, so we wanted to do something about it now. But one of the things that this grew out of was something I came up with about half a dozen years ago, which never really got traction, which was the intubation drill. When you put a tube in, look at this and how you manage a dodgy trace, and you can actually practice this. You can drill it, you can sim it. It's all objective. It's a systematic approach. The criteria are objective, so you can actually use that for quite didactic teaching as well. And we think it will be. We think it will be amenable to that. This has been adopted, this has been endorsed by the European Resuscitation Council. It's been adopted, I think, by the College of Anaesthetists of New Zealand. I think this is going to be drillable for juniors and they'll be simmed regularly on it. Sorry, second question.
So Andy, with the with the tool that you've presented to us, is it a cognitive aid or a guideline? And I guess I'm asking in terms of the Vortex being an implementation tool versus DASC guidelines being more of a foundation tool.
No, I think this is a foundation tool. You have to have acclimatized to this before you use it, I think. So you can, it's made so it's laminatable and you can have it on the wall and you can have it as an aid memoir, but I wouldn't say it's a cognitive tool. I wouldn't elevate, it's too complicated for that.
Thank you.
I had a question, Matt, because I know the answer, but I thought I better ask.
Thanks, Matt.
Noticed in David's presentation earlier where he's teaching to the camera about intubation, and you've spoken very briefly about issues with equipment at Ambulance Victoria with regards to capnography specifically. And can you speak to the interim measure? And some of the observant watchers might have noticed a separate device in the circuit in the paramedic video specifically, and then it speaks back to the algorithm in regards to troubleshooting equipment and how that procedure may just remove the need to do that.
Yep, sure. So just to rewind a little bit, so the issue had been identified, but once again, it wasn't really sure what was causing the problem as far as I know about the problem. Dave might be able to speak a little bit more informally about that. But as an interim measure, with introducing another piece of gear always is fraught with some difficulties, and sometimes it's not always the solution to the problem. Because there was such a problem with this vital bit of equipment, there was the decision made to introduce a second inline mainstream capnography within Ambulance Victoria practice to every single intubation, so that there was actually 2 capnographies now, because one of them was deemed to be unreliable. And we made it actually standard practice for every single intubation, because we didn't want that decision to be made at that point during the peri-intubation phase was, oh, it's failed on me, and then introducing another bit, and for that just to confirm that you were in the wrong place. So it was introducing a second line capnography and hopefully using those 2 pieces of information concurrently to make the right decision whether you were successful with your intubation or not.
Is there one more question?
Yeah, I just wondered what your opinion was on, I think there's like a different paradigm that we see when we're a code blue team turning up, and there's no one knows the whole story, and there's a team that works towards, someone said earlier, ALS is, we all are very comfortable doing that the same way. I see that this approach may be helpful in like streamlining, getting everyone the same, but is there a way to try and take away that initial person and their biases by just swapping out the airway operator initially, or is that inbuilt, or is there a suggestion for that?
No, but there isn't in the guideline, but because often that's not practical. But there is. I think we've kind of addressed that by hopefully empowering airway assistants and other members of the team to make sure that the airway operator can justify what they're doing. Okay, I think that's how I would answer that question. Okay, but it is a good point, because it's startling when you look at these reports that it's very rare for the initial operator to do a repeat laryngoscopy, and it may. I think I've taken out one of the key slides, but that tube that I showed you at the beginning, the first tube, that actually is not it. That's actually the esophagus. Okay, it looks like the larynx. It's something called esophageal impersonation, probably more common in children. But if you put the blade in a long way and you tug hard enough, okay, you can actually blanch the sides of the esophagus, make it look like cords. And I suspect that's what happened to one of those index cases that Tim described, because a registrar at the outset of the case intubated successfully. The patient was then extubated went off at extubation and had an emergency re-intubation and went in the esophagus. A consultant put it in the esophagus. Then 5 or 10 minutes later, another consultant comes along and says, I'm just going to have a look. Yes, it's in the esophagus, takes it out and puts it back into the esophagus. And it may be that some people are more, it's easier to elicit this laryngeal impersonation. Okay, so that's why you should see cords. You see the tube between the cords and anterior to the arytenoids. If you can't see that, one trick you can do is pop a bougie down and extubate, take the tube out over the bougie, leave the bougie in, and you get a much better view of the cords. And if the bougie is between the cords, then you're okay. But often when you've intubated someone, you can't actually see anything. Mm. So that's just a handy trick. If you are in doubt, just pop a bougie down, take the tube out over it, and then you get a much clearer view. But that may well be more common than we think, because experienced people do this rather worryingly often. It's not novices. Characteristically, it's experienced airway operators who are just more confident. Novices are probably less confident and much more likely to take the tube out, and then they don't subject the patient to prolonged hypoxia. But with that, I think John wants us to shut up. So if you have any questions, I'll be at the front, okay?
Okay, so thanks to the guys. I'd just like to say thanks to Andy, Matt and Tim for that session. I will point you to the guideline itself, which is free open access in Anaesthesia Journal, free forever, I think. You don't need a login. So just go to the PUMA website, Project for Universal Management of Airways, and you'll find it there, along with all those cases that Matt has described. So that only leaves me now, a bit later than advertised, to bring the meeting to a close. I want to say two things to you. If you've enjoyed this meeting, then all of the sessions will be available post-event. All the sessions from SAS 21 are also on our website if you really want a whole day's worth more of this kind of stuff. They were all recorded and you can watch or listen to those as podcasts if you want. And if you did enjoy this meeting, please come next year, and more importantly, tell your friends so that we have a larger audience. It would be lovely to see 200 people at our next event next year. This kind of thing is what keeps us afloat, financially viable, but more importantly present and going as a society, so we can continue to provide this kind of content and improve patient safety. So I'd like to thank you again all for coming, and thank the faculty again and all the people who've helped to make this happen. Thanks very much.